You are very welcome to this talk. Today I'm going to talk about an important subject in pediatrics, that is developmental delay. So we'll be looking at what causes developmental delay and how do we assess children who have got a developmental delay in either one of the domains or in all of the domains. So let's start. Now, at a very basic level, developmental delay is defined as failure to reach a developmental milestone by a particular age. So it means that you should know that by which age children they reach their developmental milestones. So you should know when a child started giving social smile, when a child started grasping objects, when did he start sitting without support, when did he start sitting with support, when did he start crawling, when did he start walking, so on and so forth. So you should know that by which age these milestones they are reached. So if a child fails, so if he fails to reach a particular developmental milestone, which might be in any of the domains, either it is gross motor, fine motor, vision or hearing, or social domains, by a particular age which is normal, then you would call it as developmental delay. So that developmental delay can present in either one domain, that it might be isolated only to gross motor or fine motor or social domains, or if it is present in more than two domains, then we call it as global delay. So if a child has got delay in gross motor as well as fine motor, that would be developmental delay. If he has got developmental delay in gross motor, fine motor and social, that is developmental delay, global developmental delay. So by definition, a global developmental delay is two or more domains in which the child has failed to reach his developmental milestones, which are normal for that particular age. So you should keep it in mind that there is either an isolated developmental delay if that failure is present in one domain, or it might be global developmental delay if a child fails to reach his milestones in two or more of the domains. So having said that, important thing is to know that what are these domains of development, and what do they mean when we say that a child is lacking, let's say, in gross motor domain. So where is the underlying fault? So for that you need to understand the domains of development and what are the basic physiological processes which are responsible for achieving milestones in that particular domain. So in general, most of the pediatric textbooks, they divide the domains of development into 4 domains. Some books have even gone a bit further and they talk about the 5th domain as well, which relates to personality or intelligence. But usually it's a bit hard to assess intelligence and personal development at a very young age. It usually comes after 3 years of age. So in very small children, we would just go with these 4 domains. So these 4 domains are: number 1, gross motor domain. Then we have got the fine motor domain, which is associated with vision. So vision, though, is separate, but it's very much associated when it comes down to development. A fine motor development of a child is very much dependent on his vision. So that's why when we are looking or when we are assessing the domains of development, so we assess fine motor domain along with vision. Then we've got the language, speech and hearing domain, and last but not the least, we have the social adoptive domains. So what do they mean? Gross motor domain basically deals with your axial musculature. So it all involves with your proximal groups of muscles. So, muscles of the shoulder girdle, muscles of the pelvic girdles and the backbone, all those muscles which actually help you in maintaining your posture against the gravity. That is your proximal groups of muscles. And deficiency in the gross motor domain means that there is some problem with the proximal group of muscles. So whether they are myopathies or dystrophies or any problem, but the problem mostly lies with the proximal group of muscles. So you remember that gross motor domain is equivalent to your proximal group of muscles or axial musculature. Okay. Now, fine motor. A fine motor actually deals with distal group of muscles. So in a child, we mean if the child is able to have a good pincer grasp, is he able to write, scribble, things like that, depending on the age. So that develops, with the passage of time, and it involves the distal musculature, so the muscles of the hand, sometimes feet as well. And remember that in order to achieve good fine motor control as the child is growing, he needs to have good vision, because he can only develop if he can see the object and then able to hold them. Because a child who is blind or who's got a weak vision would not be able to detect objects, or look at the objects clearly. So over a period of time, as he's not able to see, he might not be able to develop his fine motor control. So fine motor controls is related with your distal group of muscles, so your interossei, the lumbricals, the small muscles of the hand and the palm. And it also deals with your vision, so it requires a child to have good vision. So whenever you are assessing the fine motor domain, you also assess the vision, so it requires good vision. You should also keep it in mind. So whenever there is a problem with fine motor control, always assess the vision as well. Then the third domain is the language, speech and hearing. Now, a child's language depends on how much he hears or how clearly he hears. So a child who has got problems with his language, important thing is to assess his hearing as well, because a child who's got deafness, any form of deafness, whether it's conductive deafness or sensorineural deafness, would not develop a proper language. So it depends on the language, and it depends on the hearing as well, the language. And it also depends on environment and training as well, because a child needs to be talked to in order. If the child has to learn, then obviously he has to interact with the environment. So if the parents are interacting with the child, only then a child can develop his language. If he is not properly trained, or the parents themselves are, let's say, they are not able to speak, or they've got a sign language, then obviously the child would not pick up language in early years of his development, and might he might have delay in this domain, particularly the language one, despite the fact that he's got good hearing. So also keep it in mind that it also depends on the environment and training of the child. So not only the hearing apparatus should be fine, the environment should also be conducive, and the child must get an opportunity to be proper trained in the language. So this is also an important thing to keep in mind. Then we've got the social adoptive domain. Now the social adoptive domain basically deals with the interaction of the child with the environment. So in this particular domain, what we are assessing to see that how the child interacts with the environment. So his environment could be his parents, his toys and other things. So how he interacts with that. So social reciprocation, a smile, preoccupation, stereotypes, all these things would fall under the domain of social adoptive domain. So these are the 4 domains. As I told you earlier, that some books also talk about an intelligence domain, which depends how intelligent the child is, and that depends on how much he is able to solve complex scenarios, and that again depends on the age. And obviously you cannot expect a child who's 6 or 9 months of age to do complex things. So obviously when we talk about intelligence domain, it comes at a later stage. So it is not something which is uniform. It is used for children who are a bit older. That's why some books use it, some books don't. But usually, I mean, from examination point of view and from journal point of view, most of the time these 4 domains are more than enough to assess a child, and obviously these 4 domains can pick up majority of the problems associated with development. So having said that, remember, we should know what are the main principles of assessment when we are dealing with a child who might have a developmental delay. So developmental delay can present in 2 forms. Number 1, somebody might bring their child with a primary complaint that this child has got some developmental delay. So they might say that the child is not able to see, or he doesn't make eye contact, or he's not able to sit, or he's not able to crawl, or he's not able to walk, so on and so forth. So that is a primary complaint related to development. Or sometimes they might come for some other problems, and in the meantime you might pick up that the child is lacking in his development. So either he's lacking in 1 domain or 2 domains, or he's globally delayed. So let's say a child who comes because the parents are concerned about repeated chest infections, and as you are taking the history and things, you find out that the child is not able to walk, and let's say he is 4 years of age, and then you notice, though For parents, it's not a concern at the moment. Their concern is repeated chest infections. But you also find out that the child is lacking in his development. So you try to find out, because most of these things will be connected to one another. His repeated chest infections might be related to some form of pathology which is causing his developmental delay. So all things are connected. That's why it's very important to understand and do a thorough physical assessment of the child. So a child might come with a primary complaint of developmental delay, or you might pick it up as a secondary problem, though the parents are not telling you, but your examination picks it up. So it's very important, whether you are dealing with it as a primary complaint or as a secondary complaint, you should start with a very thorough developmental history. So it's important to know about the developmental milestone. So you should ask, when did the child started having social smile? When did he start having neck holding? When did he start sitting without support, with support? And you should write it down. You should also know whether the child was able to achieve certain milestone and then started, regressing, or the child right from the very beginning was not able to achieve his milestones at the appropriate age and has been lagging right from the very beginning, because they can have different meanings. And obviously some of the underlying problems can be traced, whether we know if a child has been lagging right from the very beginning, or has he been developing fine to a particular age and then started regressing. Because neurodegenerative disorder, some of the neurodegenerative disorder, the child will be having a normal development up to a particular age, and then he starts regressing and reversing back on his milestones. So once you have taken a thorough developmental history, and that should be coupled with the birth history and other points in his past medical history, because very important. Most of the problems which are related to development usually can be traced back to something wrong, either in the antenatal history or antenatal infections, or it could be something even related to perinatal events like delayed obstructed labor, something, or hypoxic ischemic encephalopathy, which could be because of birth asphyxia, so on and so forth. So a developmental history should always be coupled with a good birth history and other relevant points in past medical history. Okay, so you should keep this in mind. Once you have taken history, though history would give you most of the things, it's also very important to do a thorough developmental assessment. So the thorough developmental assessment means that you assess the child in all the four domains of development. So you look at his gross domain, motor domain, you look at his fine motor domain and vision, you assess his hearing and speech, and you assess his social domain. So you do all these things and you write down your findings. And then based on the findings, whether you find that there are deficiencies in one domain or whether there are deficiencies in two or more domains, your further workup would depend on your findings. And do not forget that whenever you have done a developmental assessment, always do anthropometric assessment of the child. So do a height and weight and plot it on the centiles chart, do the occipitofrontal circumference, and don't forget to do a thorough neurological examination, because only when you combine your developmental assessment with neurological assessment and anthropometric assessment, only then you would be able to narrow down your differentials, because the differentials can be very broad. So you have to narrow it down, otherwise, sky's the limit. So in order to narrow down your differentials, you need to do thorough developmental assessment, you need to do thorough neurological assessment, and you need to do anthropometric assessment. That would include height, weight, and head circumference. Once you've plotted that, then your further workup would be guided, like whether this was isolated, whether this was global, what were the findings in neurological domains, what were the findings on anthropometric assessment. So, and we will talk about that later on in this particular lecture. So just to summarize it, whether it's a primary complaint or a secondary problem you pick up on your assessment, always take a thorough developmental history, which should be associated, or which should be actually coupled with his birth history and other points in relevant points in past medical history. Then do a thorough developmental assessment, also do a thorough neurological examination, do his anthropometric assessment, and then it would guide you what further workup you need to do in order to reach your diagnosis. So I hope these points are clear. So let's move forward to the next slide, and let's talk about the cause of developmental delay. It's very easy. I told you that there are four domains of development: the gross motor, the fine motor associated with vision, the speech, language and hearing, and the social adoptive domain. So you can have deficiencies in either one domain, which might be gross motor only, which might be fine motor only, which might be vision only, which might be social adoptive domain only, or you might have deficiencies in two or more where it would become a global developmental delay. So let's talk about the causes. Okay, so let's say if there is problem in gross motor domain. So if only the gross motor domain is affected and rest of the domains are not affected, some of the reasons that might be responsible for that, the most common one is cerebral palsy. Kids who are born with cerebral palsy, because that happens. Cerebral palsy basically, is a sort of a non-progressive damage to the brain. It usually manifests as motor deficiency, and it could be because of any reason. It could be because of birth asphyxia, it could be because of stroke. There are so many reasons for that, but it's a non-progressive lesion, so it's like the damage has occurred, but that damage is not progressing. And usually, as I told you, that it would progress in most of the cases with problems in the gross motor domain, though sometimes it can present with problems in other domains as well. But for the sake of simplicity, I would say if you only find gross motor delay, think number one of cerebral palsy. Then, because you know that the proximal group of muscles are involved, most of the muscular dystrophies, Duchenne muscular dystrophy, Becker muscular dystrophy, different types of myopathies, congenital myopathies, they would present with gross motor delay. So muscular dystrophy is a very wide group. So anyhow, you don't need to remember everything, but at least you can, sort of narrow it down to problems of the proximal muscles in the form of muscular dystrophies. Some of the other diseases that can cause only gross motor delay are SMA, spinal muscular atrophy. There are different types. Polio, especially in developing countries. Not all the developing countries. I think it's just like 2 or 3 countries where it's now a problem. Rest of the countries have almost eradicated polio. But anyhow, where it is still endemic, you should be thinking about polio in those. Spinal cord problems. Some of the congenital spinal cord problems can present with gross muscular problems leading to gross motor delay. And last but not the least, malnutrition, which is common in the developing countries. So malnutrition itself, because obviously the child is malnourished, his musculature is weak. So what would happen is that you might find that the child only has got gross motor delay. So these are some of the causes that are responsible for if you find delay in the gross motor domain only. If the child is lacking in fine motor domain, so if the child is not able to hold objects, he hasn't got a mature pincer grasp in all. So first of all, you need to look for visual problem. So always check the eyes in that case. So you would need an ophthalmological opinion if you have got a child who's got fine motor problem, because most of the time it might be associated with visual problem. So the visual problems, and again the group is very wide, on congenital cataract, congenital ophthalmus, so on and so forth. It might be because of cerebellar problems as well, or sometimes because of stroke as well. So that also keep that thing in mind. And sometimes it might be caused by anatomical defects. So if a child who is born with arthrogryposis, where there are congenital contractures, or is born with missing limbs and things, so obviously you cannot have any good fine motor control, and the fine motor domain would be lacking in that particular child. So always always think about anatomical defects in such a case. Then the social adoptive delay. So if there is child is only lacking in social adoptive domain, then obviously think about the autistic spectrum. So autistic spectrum is a large spectrum. On one hand, it's got mild, and the other hand, it can be a child can be severely autistic. And they usually have got like problems with the reciprocal social interaction. They've got speech problems with them as well in most of the cases, and there are stereotypes. So autistic spectrum disorders can give rise to problems in the social adaptive domain, and usually in Europe it's very common. So keep that thing in mind. Certain genetic and neurodegenerative conditions can also give problems in the social adoptive domain, like for example genetic, like for example in males, Fragile X syndrome. Children are autistic and they have got problems in the social adoptive domain and can have intelligence impairment as well. In girls, neurodegenerative conditions like Rett syndrome, which is caused by MECP gene deletion, that can cause problems with the social adoptive domain as the child grows. So keep these things in mind. And if you find that there are problems in more than two or more domains, then as I told you earlier, that the definition is in that case would be a global developmental delay. So global developmental delay means two or more domains of development in which the child is lacking. So in that case, there could be many. The list is a huge one, but again, some of the common causes. Number one, hypothyroidism. So hypothyroidism, congenital hypothyroidism, or even acquired hypothyroidism can be a cause of global delay. One of the most common causes is perinatal insults leading to hypoxic ischemic encephalopathy. So in developing countries, this is one of the most common reason, and to some extent even in developed countries, we still see kids who had a perinatal insults leading to hypoxic ischemic encephalopathy, intraventricular hemorrhage, and again eventually leads either to cerebral palsy or leads to global developmental delay. Some of the genetic and chromosomal disorders, obviously Edward syndrome, Down syndrome, again, they can cause global developmental delay. Structural brain disorders like holoprosencephaly, lysencephaly, neuronal migration defects, etc. They can also give you global developmental delay. Some of the metabolic disorders, which are caused mostly by enzyme deficiencies like Leishman, Tay-Sachs, Sanfilippo mucopolysaccharidosis. The list is a huge one, literally a huge one. So those metabolic disorders are, majority of them are associated with global developmental delay. Certain neurodegenerative disorders like Rett syndrome, adrenoleukodystrophy, metachromatic leukodystrophy, white matter disease, they can give rise to global developmental delay. And last but not the least, congenital infections. So congenital infections which are acquired in utero, like congenital torch infections, can also give rise to global developmental delay in children. So in a nutshell, the bottom line is you have to see whether the delay is in one domain or is it in two domain. In other words, it's a global developmental delay or more than two domain, like then it will become severe global developmental delay. And based on that, then you can have an idea that like which could be the underlying cause. Again, the list is very huge. So then we need to trim it down by having an appropriate workup. Now, how do we work up? This is a $1 million question. Like let's say you have identified a child who's got problem in one domain or has got problem in two or more domains. What would you do after that? I mean, obviously you want an answer for that. What has caused that? So workup is very important, and I have made an algorithm which I have taken from different books, and I hope this is a simple one. This would help you in understanding how should you approach practically. I mean, let's say if you are working in a busy clinic or in a busy hospital and you get across a child who has got developmental delay, so then fine, you've taken the history, you've done the assessment, you've come up there. Now what's next? What are you going to do? So let's talk about that. Let's say I will make it easy. If you find that the child is only lacking in gross motor domain, so he has only got problems with his proximal muscles, rest of the domains are fine. You have done his fine motor, which is fine. You've checked his social adoptive, hearing, speech, everything is fine. So in that case, if a child who has only got problem in the gross motor delay, the best screening tool is to do a CK level, creatinine kinase level. So you always start by taking bloods and doing CK level. So you start. So best screening tool in that case, even if somebody asks you in exam, if there is problem with the gross motor domain only, what is the best next screening test? CK levels. So you will do the creatine kinase level. So again, there are two possibilities. Either you get a high creatine kinase level or you get a normal. So if you get a high creatine kinase level, so most probably you are dealing with some form of dystrophies. So what you do? The next step after that would be to do gene studies for certain disorders which give you isolated problems in the gross motor domain, like you would do the gene study for the DMD, Duchenne muscular dystrophy, which is an X-linked recessive disorder, or spinal muscular atrophy, which is an autosomal recessive disorder. So you can do the gene studies for that, like SMA1 gene, or you can do the DMD gene studies, and plus minus you can do a muscle biopsy as well. So muscle biopsy would give you an idea also that what's wrong with the child, okay, what sort of disease it is. So gross motor delay, best screening tool, creatine kinase. If it is high, carry on with gene studies and muscle biopsy. If it is normal, then what would you do? The next step would be to do EMG and nerve conduction studies. So you will do electromyography and nerve conduction studies to see if there are any neuropathies which might be responsible for causing gross motor delay. So the next step should be electromyography and nerve conduction studies. Okay. If the child has got problems with fine motor domain only, fine motor. So I told you fine motor is associated very closely with vision. So the first thing, now you find the gross motor is fine, social adoptive is fine, hearing, speech, language is fine. Problem is only in fine motor. So what you do, the next step would be to take an ophthalmological consult. So you would do a complete ophthalmological examination. Obviously, you won't do it as a pediatrician. Basically, you would consult the ophthalmologist, and they can do a complete eye examination. Usually in small kids, they have to sedate them and do direct and indirect fundoscopy and check their eyes, anterior segment and posterior segment and everything. So that would give you an idea whether there is something wrong with the vision or not. And that can be followed by Ctn Mri brain, because obviously if there are problems with the cerebellum, structural problems with the cerebellum, or there are some other issues like an old stroke or infarct or anything, then the Ctn Mri brain would be able to pick those things. So for fine motor domain delay only, the next step is what? Complete ophthalmological examination, and then followed by CT and MRI. MRI is preferable as compared to CT. If the child has only problems in the speech, language, hearing delay, nothing else, the child has got either deafness or has got language problems, then the next step would be to do an audiology. So audiological examination, complete audiological assessment would give an idea whether this is conductive deafness, whether there is sensorineural deafness, or there is no deafness at all. Okay, so the next step would be audiology assessment, plus minus, depending if let's say if you find the reason on based of audiology sensorineural deaf, even sometimes that to see what's causing those things, an MRI brain would be helpful. So because MRI brain, if there are like internal lesions which are responsible for deafness or for language areas, like in the parietal lesions, the parietal lobe, congenital or acquired, they would be picked up on MRI. So for speech, language, hearing domain defects, where the defects are only localized to this particular domain and rest of the examination is fine, you would go with audiology and an MRI brain. What if you've got a global developmental delay? 2 or more domains are defective. Okay, so the best initial screening in that case is to do what you call is your normal blood test. So you will start with full blood count with your LFTs, liver function test, urine electrolyte, thyroid function test, CK levels, bone profile, and followed by ophthalmological opinion. Because 2 and more domains are affected, now the test needs to be more broad based. So you do a full blood count to see if there is any recent infection which might be responsible for that. Liver function test would let's say in certain diseases which cause global developmental delay, there is usually liver involvement as well. So if there are deranged liver function tests, that can also give you an idea. Thyroid function tests are good to pick up hypothyroidism. Urine electrolytes can give you an idea if the underlying problem is causing issues with sodium, potassium, bicarbonate, etc., acid-base balance. Creatine kinase level obviously can point if there is any sort of a muscular dystrophy as a part of the global developmental delay. Bone profile would give you an idea how strong or weak the bones are, followed by ophthalmological opinion, because some of the metabolic and neurodegenerative diseases have got pathognomonic ophthalmological features which can only be picked up by a detailed ophthalmological assessment. So it's very important you do the basic line investigation, including CK, TFTs, UNEs, bone profile, and once you have done that, then you send the child to the ophthalmologist to get a detailed ophthalmological assessment. Once it has been done, then it should be followed by CT or MRI brain. Again, MRI preferable to CT because MRI is very sensitive in picking up structural brain problems. It is also very good in picking up gray matter disease, white matter disease, congenital problems or defects in the brain. So that can be picked up. If seizures are also a part, now you don't look for seizures in developmental assessment, but I told you that when you do the developmental assessment, you also do a neurological assessment. So in the neurological history, if there has been a history of seizure, then you will also do an EEG, electroencephalography of the brain. If the child has got dysmorphic features, when you examine him, then you should also do karyotyping, because some of the problems can be picked up on karyotypes, like Down syndrome, Edwards syndrome, trisomy 13, so on and so forth. RACGH is another good technique where karyotyping just picks up the chromosomal disorders. RACGH can also pick up some other disorders as well. And if nothing, then gene studies or gene analysis is also done in certain university hospitals. So that can also be requested. If there is an element of organomegaly like hepatosplenomegaly or a large heart on chest x-ray, then you should do blood sugar levels and also look at the acid-base balance problems as well, because certain metabolic diseases might present in this way. And if you find anything wrong on the blood gas, or anything wrong with the blood sugar, then a metabolic screening is important, where you would look for certain metabolic problems. Again, for that, blood has to be taken, and not every lab does that. There are specialized labs which do metabolic screening. And again, there are various diseases, metabolic diseases, which can present with global developmental delay. So that's how you would proceed in case of global developmental delay. And in most of the cases, you will come across global developmental delay. So remember, you take basic, you do the basic blood test, which include full blood counts, LFTs, UNEs, bone profile, creatine kinase level, and then followed by ophthalmological opinion. Next step after that would be to do a CT or MRI. After that, if there is dysmorphism, you would go with karyotyping, RACGH, plus minus gene studies. And if there are problems with the acid base or electrolytes, then you would also go for metabolic screening. And in this way, the results of these tests can then guide you what is the underlying pathology which is causing a global developmental delay. So I hope this you find it easy to understand that what should be your workup approach once you identify whether the developmental delay is in one domain or is it a global delay. Okay, so let me give you a case study at the end, okay, to just have an idea how we approach. So I have just made a hypothetical simple case. So here we deal with a 3-year-old male child who is brought with a history of repeated chest infections. So his primary problem is that he's getting repeated chest infections, and again he has picked up an infection, and the parents have brought him for that particular problem. But apart from his chest infection, you on your examination you find that he weighs 7.5 kilogram. So he seems to be quite malnourished. So he's small for his age. He can only sit with support. So at 3 years of age, he is sitting only with support, which you know is a developmental milestone which a child should achieve at 5 and 6 months of age. So though his physical age or chronological age is 3 years, his developmental age in the gross motor domain is around 5 or 6 months. He cannot talk, but only babbles. So he is lacking a baby babbles 5-6 months. Again, you see in the speech, hearing, language domain, he's 3 years old chronologically, but his developmental age is that of a 5-6 months old child. He makes some eye contact, but cannot grab toys. So at 3 years, he should be able to do many things. He can't even grab toys. He makes eye contact, but he cannot fix on different things. So it simply means vision and fine motor domain is also affected. He cannot stand, obviously that is another delay in the gross motor domain. Neurologically, so you have done that and you find out that he has got now a delay in the gross motor domain, he has got delay in vision and fine motor domain. Okay, and obviously it is 2, so it becomes a global developmental delay. And then neurologically, on neurological examination, because I told you neurological examination is an important thing when you do your developmental assessment as well. So on neurological examination, he's got hypotonia of the muscle, so his muscle tone is reduced, though the cranial nerves are intact. So what domains are affected? So here you can see the baby can only sit with support and he cannot stand. So this deals with the gross motor domain, because to sit you need to have strong musculature of the back. To stand you need to have strong axial muscles. So which domains are affected? Number 1, gross domain. He makes some eye contact but cannot grab toys. So his fine motor and vision is also affected. So if 2 domains are affected, then it becomes a global delay. So this child has got a global delay. Now, after doing basic tests, I told you if a child has got global delay, then you will start with full blood count, urea electrolytes, LFTs, thyroid function test, CK levels, bone profile. So let's say you have done that. Now, what would you do after that? So once, in the case of global developmental delay, once you've done the basic test, the next 2 steps would be: number 1, to take a ophthalmological opinion. In other words, the child needs to have a complete direct and indirect fundoscopy. And number 2, to have a Ctn Mri the brain. And let's say you have done that, and here this is a picture of his fundus on the right side, and here you can see on the left side, here you can see this is his optic disc, and then you can see the blood vessels. I can't see any dilated blood vessels, but here you can see a red spot surrounded by some halo. So this is the macular region. So he's got a macular halo. In the center there is a dark spot which we call as cherry red spot. So he's got a cherry red spot on his macula surrounded by a macular halo. So obviously, you know, there are a few diseases in which you get cherry red spots. So at least your differentials are narrowed down. Now, the next step is you do a Ctn Mri. These are the Mri images, D2 and D1 weighted images. And here you can see that there are hyper intense lesions in the white matter and hypointense lesions in both, you know, subcortical areas. These are the subthalamic nuclei, and then you can see the caudate nucleus is also affected here as well, and here as well, with subcortical hypointensities. So when we combine all these things, this global developmental delay, along with the cherry red spot, along with the involvement of the basal ganglia, the caudate nucleus, and the subthalamic nuclei and part of the white matter, it becomes very much pathognomonic of Tay-Sachs disease. So basically this child has got Tay-Sachs disease, and you can further then confirm it by enzymatic studies. So he's got a Tay-Sachs disease. So this global developmental delay is because of Tay-Sachs disease. So his weak musculature, because he's got a weak musculature, he's got repeating chest infections because his intercostal muscles are so weak. His lungs have got less compliance, so obviously it becomes a rich medium. The secretions are not properly, you know, you cannot get rid of these secretions, so that secretions become a rich medium for bacteria. So he's getting repeat bacterial infections because of his weak musculature. So he's actually delayed in the gross motor domain, and that is because of an underlying problem, which is Tay-Sachs disease, which is an enzymatic defect. So this way, a global developmental assessment leading to identification of problems in various domains of development, you know, we do the relevant workup and eventually we reach the underlying problem. So we find out that this is the actual problem which is causing all these other problems, which are just the branches of the underlying disease that the child has got. So this is how we do our developmental assessment, and we do workup for a development assessment to find out the underlying problems. So I hope you have enjoyed this video and you have learned something new regarding assessment of development in a child. And if you have liked my videos and you haven't subscribed, so please do subscribe to my channel, because that gives me motivation to make further videos for you people. And if you have liked my videos, press the like button and do share it with your friend, so that the knowledge is spread and the learning process is carried forward. Thank you very much and have a good day. Bye bye.